Hey people. Hello, hello. I've never done a live stream on YouTube before, and I just realized that, and I was like, let's just give this a try, to see if y'all like it, if I should keep doing it. I just got off a call with my all access members. I have a monthly thing where you can subscribe monthly and get access to all of my content. And one of the features I'm adding is like a live monthly call. Just got done with that. I'm in the live mode right now, so let's just talk about things. I wanted to share the content that I talked about. So, one of my big tips for nurses who are new to a unit, and more specifically new to nursing and new to a nursing unit, is I've seen people come in hot, like coming in hot with their kind of level of confidence. Or I've seen people come in like ice cold, like timid, mousy. Oh, I don't want to be here at all. I'm terrified of everything. And um wait, okay, terrified of everything and don't want please, dear God, don't speak to me. And get talking to them is like pulling teeth. So how can you show up on a unit and not make those mistakes? So in the Breakthrough ICU course I talk about earned authority versus like commanding respect. So baseline is like when you're on a nursing unit or in any job, like there's a basic level of human respect you should have, even if it's in a high stress job, even if people are doing, you know, not doing so hot and having a tough moment, you're still like there to take care of them and should be respected just as a human. Not like, hey, I've been a nurse for however many years and I have this authority in this space. There's a difference between that and just like respecting somebody as a human. You know what I mean? Like we tend to assume, "Oh, I'm new here. I don't know anything, so I don't deserve to be like respected." But there's a difference in that kind of respect. There's the respect that we should have in like basic decency when speaking to one another versus like earned authority. So like I think people will say, "Oh, I haven't been here long enough." Like, or if somebody, "Oh, this is a well-respected person." Okay, great. A well-respected person really translation means they have earned significant authority in this space. That comes with a lot of time, a lot of reps, a lot of, your showing up and doing the right things and you're reliable and all that kind of stuff. Um, that is earned authority. And when you show up on a unit, you should get some basic human respect because you have not yet earned authority. And if you come in hot, you act like what it feels like, what it comes across as is you feel like you have undeserved authority. So I've seen that before. People coming in hot and very like and it's from a place of I want to look competent. I want to look like I know what I'm doing. I want people to respect me. So I'm going to really communicate all the things that I know and how valuable I am, and I'm going to, well, it's a little much and that can come off arrogant. So you want to really watch out for that. And the goal that all of you would have is I'm going to start on this nursing unit and then I am going to over time with how I show up every day, what I do, how I handle mistakes, how I build rapport with people. That is how I'm going to earn authority over time in this space. Okay. You're not gonna also, though, come in and be, like, timid and mousy and, like, "Oh my god, I'm no dear God, nobody talk to me, I'm so scared." Like, that is also very difficult, like, not a great, like, impression to make, I guess. So, one of the comparisons I like to make is, especially when we're talking, like, critical care level, the way people, I think, tend to view this is if you think about it, getting a job on an ICU, like you struggled through nursing school, you worked really hard to get through school and graduate, then you do all the NCLEX stuff, and then oh my gosh, I got this ICU job right out of school. It feels like you reached the top of the mountain, you've achieved your goal, you got the job, now you just need to be shown around and you're good. And really, what it's like is you just got to base camp of the mountain, okay? You figured out your gear, you figured out how to do this and all these things. The journey has only just begun, kind of thing. And that can be a little bit of a reality shock and be difficult. And people think, oh, I made it. This is what I needed to do. And then that can really kind of facilitate that mentality that I'm here where I need to be. Or I've finished my journey. So another analogy, and I know you shouldn't do too many analogies, but I just feel like these work. Okay. So bear with me. I feel like people tend to view it as, let's say 40 people applied for 5 positions on your unit. That's kind of like 40 people tried out for a basketball team with 15 people on it, and 10 of them were there last year and are definitely on the team. So there's 5 people who are going to make this. They're going to make the cut. And this end up team of 15 people is going to be who makes the team, and this is the team. Nursing on a unit, especially in like an emergency department in a critical care world where we've got people deteriorating quickly, things changing fast, is very much like working on a team sport situation. Like, we have to help each other. And the people who have been on the team, they know each other's personalities, good and bad, but they have awareness of how everybody functions on the team. They know who's grumpy till 10 a.m. and who to not talk to until 10 a.m. And they know who is a burst of sunshine the moment they walk in the door, but they need a break around 2 o'clock or they're going to get real grumpy, or who's going to be really blunt, who's going to beat around the bush. Like, you learn personalities on a basketball team, much like you do in a nursing unit. So if you are that brand new nurse on this unit, you don't know all those personalities, much like if you're the brand new one of the 5 newbies on this basketball team and 10 people were there last year. You don't know the playbook. You know how to play basketball, but you don't know the playbook. You don't know the tendencies of all the people on the floor. You don't know their strengths, their weaknesses, let alone how to play into that and how to like hold your own yet. But you do know that, yes, I have demonstrated this basic level of competency to make the team. Now, to get to the point to function successfully within the team takes time of just reps physically being there and getting to know people. So that's one of the reasons that I really encourage people who are new to a unit to observe a lot. Watch how people talk to each other. How does this person delegate? How does this person respond when someone is delegating to them? What did you observe that did not work so well? Oh, okay, learned this about this person and this about this person. And you kind of are like really absorbing a lot of information so you can know how to approach situations. And when you come from this eyes wide open, understand what's going on and the learning curve ahead, it helps you get into the zone easier and with less stress. So I hope that makes sense. And, if anyone has any questions, drop them in the chat. Love to know who's watching, where you're from, kind of thing. If you're a nurse and where you're working or what unit, or if you're struggling with anything, would love to hear if anyone has any questions. Happy to help. I love helping nurses in all areas. And if I don't know, I'll find out the answer. But that's one of my big things, is the commanding respect and not allowing yourself to be disrespected, because you do get and should have in a professional environment a certain level of like human to human respect. We're not going to scream at each other. If we're mad at something or this wasn't done or whatever, we're going to, hey, I hear that you're upset, but please do not scream at me, kind of response, that kind of stuff. So we want to be able to command respect and not be this like super mousy, intimidated. People can talk to me however they want because I don't respect myself. We don't want that. We need to be a nurse with a backbone, even if you've been there for 2 minutes. That doesn't mean that somebody gets to scream at you, right? But that is very different from the nurse who has been there for 20 years and has earned authority. So there's such a difference in earning authority over time and just like the basic respect that everybody on your unit and every human, one another, needs to afford each other, if that makes sense. So that was my little thing. I talked about that with my all access members and thought, hey, maybe I should throw this on YouTube and see what people think. So, does anyone have any questions? I'm super new. Let's see, wait, live chat. Okay. Oh, Love your videos. I'm a new grad in the new ICU. Yes, welcome, welcome. I'm so excited for you to get in the ICU. It is an intimidating but very, very rewarding environment. Um, so excited for your journey. If anyone else has if anyone has questions, I would love to help navigate things. I've worked in ICU, I've worked in med surge, been an educator for a while, care so much about the newbies, and I just want to let you guys know I'm helping out with a girls basketball team because I played basketball in college for a little while, and my friend is coaching the middle school girls basketball team, so I'm going to help out. And the other day, one of them found out I was a nurse, and she goes, "You're a nurse? Slay, y'all! I've been riding that high since that happened yesterday. Let me tell you, that felt amazing to have the sixth grader say that. So, if you're in nursing school and you're getting ready to become a nurse, like just like I don't know, just a sixth grader thinking I'm cool, like, yeah, it's gonna last for a little while. We're gonna hang out on here for a little while and see if anyone has any questions or where are people working? How's nurse life going? What's going on in nurse world that makes no sense or you hate, you love? This is my first stream, by the way. So we're seeing how that's going. So I talked about that with my all access members. And then next week, I'm going to talk with them about how to deal with a over-engaged preceptor or a disengaged preceptor. So that preceptor that won't let you do anything by yourself versus how do you deal with the one who's not. Oh, we got another question with the nurse who's super disengaged. All right, we've got a new grad psych nurse and struggling with admissions and med recs. Oh boy. Oh, psych nursing. Awesome. My husband is a therapist. So I've get to hear a lot about that life. So admissions and med reconciliations. Help me out. Give me some more information about what is it? Is it the time management of getting through them in an efficient way? Are they one of the things I found as a new nurse on a unit is everybody has their own process for admissions and expects you to get through it in a specific way, or has unrealistic expectations for time. One of the things that what I would do with admissions, and I'm not sure about your flow, but when I would do admissions before, one of the things that I liked to do was, there's things that are high priority on there, and then there's things that are not as like do or die, right? And I'm sure with these things you have some sort of like time expectation of when you get them done. So like I would be, all right, this is my admission paperwork. And it can be difficult if you don't get very clear expectations or clear explanation is what I mean of what you're supposed to do. Sorry, hold on, guys. Yes, time management and struggling with talking with the doctors to get admission orders and PRNs. Yes, and being a new grad too, you might not realize yet because you just haven't had the reps yet of what is high priority and what's not, and it also depends to if you're on a unit where like you're getting an admission at 4 p.m. It's getting ready to be the physician on call. So my routine with admissions, and this might be different in inpatient hospital versus, I'm not sure if psych nurse meaning like a residential treatment. Time management and confidence. Yes, that's so challenging. So what I would do with admissions is you kind of quickly understand the high priority things. Um, so when I would have someone come in and they're on the unit, they're in pain, and certain meds they need pretty quickly. I would be looking to see what orders I already have. Inpatient psych. Okay, great. That's helpful. So if I know I'm getting a patient and I can kind of anticipate, hopefully before they're getting there, maybe you're able to look at the chart, see what orders you do have. One of the things I liked to do as soon as the patient got to my unit, because I couldn't do it before then, was release all of any orders, um, and especially the medications, because that way the pharmacy can start working on them. And then my time management would be to go into the room, do the admission, but like within your admission, there's things that are high priority that you need to do kind of quickly, especially I'm not sure if you have any IV meds or anything like that, but like high priority things, I do those first. The must-haves, I try to get done as quickly as possible. So, like, if you're gonna have to give a med that's gonna sedate them a bit, and maybe your protocol is you have to get a set of vitals right away, usually it would be like, "Okay, I'm gonna make sure I get those things done, the vitals done so that I have this information so that when I assess the patient and call the physician, I have bare minimum information." I don't necessarily need to go into our socioeconomic assessment and this kind of stuff, but the high priority things to be able to address the immediate needs. So, like in the inpatient world, um, you know, blood pressure management, like on the cardiac unit. Okay, yes, you have a statin ordered and Nicolase, and you have, I don't know, whatever ordered. But like, okay, I saw in the emergency department what your blood pressure was, and I'm gonna wanna give you your low pressor as quickly as I can. So I will peek at what I think is higher priority. Now, the more experience you have with your patient population, the quicker you're gonna pick up on this. Because it is different with psych than like neuro or something like that. I'm sorry, my throat hurts. And then, Charmaine, hang on, I have a good time management tip, but I do wanna finish Addie's. So it can feel like I have to get this full admission done and all this stuff, but I want you to pick highest priority things to notice and start picking up on, hey, I need to make sure I get this done and this done. So, like let's say I had my admission on my unit and these principals do transfer. So I'm sorry, I don't know. I never worked inpatient psych, so I don't have like the exact like translation, but bear with me and think of how this can apply to yours. But like, all right, I have a patient coming up. I know they're in pain and I know that they have a really high blood pressure. So when they can't come up, if you can't, I don't know if you have a CNA or what or how that works, but like what I would tend to do and what our unit would do, if someone was getting an admission, a few nurses would help them just get the patient settled. And what I would do is they would be doing things like get their weight and that kind of stuff. I would do a quick physical assessment to make sure we're not dying or have like a bleeding wound or whatever it might be, or if they're on oxygen and needed that set up or whatever the respiratory situation was, if I needed to facilitate something quickly. Then I have a full admission I have to do, but I release the med orders first. And when I'm doing my assessment, I'm also talking to the patient so I can kind of identify what is their priority too. Because what are they gonna keep asking me for? So if it was a patient after surgery, they're gonna ask me for food, pain and food all the time. That I know I need to know I know I need to have a diet order, and I know I need to have some sort of pain medicine on like going, like or like ordered so that I can grab it when they need it. So yes, dressing changes and knowing about that stuff is important, but for the patient's safety, for their immediate needs, I want to kind of anticipate what those kind of things are going to be, move that up the priority level, and then the but the things on the admission where it's like, okay, do you feel safe at home? Very important question to ask, but let me get the must-haves addressed first before I get into those things, if that makes sense. So think of prioritizing not the admission as a whole, but break the admission into smaller pieces and do the highest priority things first. And then as you get your head above water, then you can go back and fill in those blanks. Um, and if you do that first, then you can identify that. You can have your conversation with the patient, assess, you check the PRNs, and maybe they do have, oh, I really need this, or I'm off on this. I haven't had this in a certain amount of days, and blah, blah. So then I'm not sure what your flow is, but maybe you do need to call the physician when the patient arrives. And what I would tend to do is do my very quick assessment, not this very, very detailed, but like my abbreviated assessment, and chat with the patient. And then I would um, quickly review the chart too. And then I'd call the physician to let them know that the patient was here and for them to assess. And then if I had this high priority thing where they're having terrible pain, they're gonna ask you about this or whatever, then they have that top of mind too, and you can also field some questions. So I hope that makes sense as much as it can. I think those principles do apply in psych. What a great job though. I hope you're enjoying it. Would love to hear what you think about it. And how about I'll talk about the time management with Charmaine here. So here's my favorite time management tip. And I talk a lot about time management, and I have a podcast episode on it. I think I have some YouTube videos. I definitely talk about it in all of my courses. Is this goes contrary to what you are told in school, but my thing is, let's say you're on a unit and you have 5 patients, okay, and nursing school and the NCLEX does a great job of preparing you for urgent situations and emergent situations. I think you can all identify which patient is dying and who needs you to drop everything. But that doesn't happen all the time. Like almost all of your shifts, especially if you're in a med surg world, are not starting off with dying prioritization. We need to learn prioritization where everybody's fine, everybody's okay. Now what do I do? How do I work through my patient load in a way where nobody's dying? How do I do this? So when everyone is stable, no one has immediate needs. Let's say your day shift and your patient's first meds are start or do it. Let's say, oh, I'm going to be generous, 9 a.m. Let's say you have 5 patients and they're all their meds, and all of them have meds. Maybe one of them has an 8 a.m. med, but the rest have 9 a.m. meds. None of them are screaming in pain or needing anything immediately. How do I know which one to see first? And I think that if you can front load the beginning of your shift and are strategic at the beginning, it sets up the rest of your shift to flow better so that you're not already behind. Had somebody message me about this 2 days ago because of this tip. I think I shared it on TikTok, and some nurse educator reshared it and was like, never do this. It's not what you're supposed to do. Let me share this, and I would love to hear your perspective. But if I'm on MedSurg, I have 5 patients, right? They're all stable. I have walkie-talkies that have like certain things that just need to be done. They feel fine, but we're waiting for a med level or waiting for clearance on this or whatever. And they'll take their own pills. They can tell me what's wrong. They can even take themselves to the bathroom. Lord Jesus, thank you. Okay. I'm going to see the low maintenance patients first. And usually, how a hospital nursing unit will allocate patients is so that one nurse doesn't get all of the very sick patients. They spread them out. So, usually, you have 1 or 2 sick patients for your unit, and then others that are doing fine but need a little extra help. So, what I do is I save those for last, those sicker ones for the end, because they're going to need more time. And they should get more time because they have more complex needs. But I have an entire patient load here that I'm responsible for. So if I know that my higher need patients are okay, and I'll do my bedside report, check in with them. Hey, I'm going to be back in about an hour. Is there anything I can get for you right now? And see if they need anything immediately. Give them an expectation of when you're going to be back, because then maybe they'll save their call light for when you come in with their random question they thought of or something like that. And then I go knock out, not literally, but figuratively, seeing all of the lower acuity patients first. Because if I start with this sicker guy, that's going to take me 45 minutes to just get through the meds and assessment. I'm going to be late on the rest of my patients, and I'm going to be catching up until 1 p.m., like while I'm getting new orders and things like that. So, oh, good. Eden. She says, I'm a new grad nurse and med surg, and I do this too. I do all my maintenance care patients first. Ooh, I love how you said that. Maintenance care patients first, and then focus on higher needs last with washes. Yes. So, like, you do first round, first sweep, where you see the lower acuity people, get those done, and then see your higher need one. And then what usually by that time that you're done with that higher need patient, it's time to round on the other ones again. They may have later meds due, or like what I do is I don't do any dressing changes until later morning or like after I've seen everybody. I get my meds done, I get my assessments done, and if there's any like higher need, like maybe there's a bowel prep or maybe there's someone's going off for a procedure. Okay. But if what I will do is when I do the second round is when I change dressings and look at wounds and those kinds of things, because those are important to do. But in terms of the hierarchy of the tasks, assessing your patients so you know what the heck you're dealing with and if we've gotten worse since the last assessment, and so you can be informed when the physician's round, is that along with medication administration higher priorities than a routine dressing change. Okay. So, and also bathing. Yes, bathing and dressing changes are important, but in that hierarchy of needs and of crammed time management, you really have to, like I was talking with Nurse Addie, here's like the admission assessment, but what's the most important thing of the admission assessment? Or here's what the patients need. What's the most important aspects of what they need? And let me do those first. It's not to say the other things aren't important, but it's just like when I have precious little time, I have to focus on those things first. So I hope that that can help make sense of some time management tips. In terms of confidence, yeah. So here's my spiel on confidence, and I talk about this a lot in my blog posts, my email newsletter, my podcast, because you can teach clinical skill all day long, and people can learn book knowledge, but if they don't have confidence in themselves, it makes it pretty difficult. Like people can dread it that more than anything, and confidence can be hard to muster, especially if you don't feel so great. So or or your expectations were in a completely different place from reality. So number one with confidence, I think it's to gauge your expectations accordingly. Like if you're a new grad and you're expecting to be performing like a highly experienced nurse, and every day you're going to feel inadequate because your expectations are significantly are very unrealistic. Okay. So it's important to gauge your expectations and you may need to reset them. Unfortunately, nursing school kind of doesn't set us up for success in this because, nursing school is hard to get into. And at the beginning of nursing school, people say, look to your left, look to your right. One of you is not going to be here by the end of this program and all that. And we really puff people up. And then we puff them up with the NCLEX and then with the getting your license. So you're like on cloud nine. And then you start this job. And like I mentioned before, you think you're at the top of the mountain, but you're just at base camp. And it's a reality check to turn and look and see, oh my God, I still have an entire mountain to climb. And then you can just, every time you mess up, feel like it's just further evidence of how inadequate you are. And it's very confirmation bias. In reality, you're probably exactly where a new grad in that area should be because you got the job. You've shown that you have this level of competency. And like I talked about in this call with my members, um, it's like a basketball team. When you make the basketball team, like you've shown a level of competency in this skill of basketball to make the team, but you don't know the nuance of the team yet. You don't know the playbook. You don't know the personalities. You don't know all of the coach's personality. You know the goal to win the game or to keep your patients alive and get them progressing towards discharge, but you don't know the nuance of this environment yet. So I think one of the keys to building confidence as a new grad is to have realistic expectations. The second thing is familiarity really builds confidence and a sense of mastery, and I want you to take, like, small things that you do better and perform better at, count those wins. I think a lot of people tend to think like, "Oh, oh, great, I got 1 IV. I should be doing this really," like, anytime someone does something well, they don't acknowledge it and just say, "Well, I should be doing better." And it makes it so that you feel inadequate every shift, and it's very difficult to muster confidence with that kind of critical self-talk. So, I think that it's important to acknowledge your wins no matter how tiny they are, and if it is something you're really struggling with, I like the idea of just, like, even in your phone or in a journal, writing down 3 tiny wins from each shift, and then as you progress through your orientation and your new job, you're gonna notice those tiny wins become more and more complex, and it feels really great to scroll back and see, "Hey, 4 weeks ago, I was super happy that I could put on the telemetry leads correctly, and now I'm getting an EKG without anyone showing me or reminding me," like those kind of things. And when you're in the midst and in the thick of like this really complex learning process, having that perspective can be challenging. So if you can kind of create systems to set yourself up for success mentally, that can be a game changer. Um, so those are my tips for time management and for confidence. So I hope that helps. Does anyone else have questions? I do have to go. My kids are going to be off school in half an hour, so. But I'm curious if anyone has any questions, comments, thoughts. Where are you a nurse? Where are you working? Those kind of things. Oh, I've been doing a lot of talking. My throat hurts. My water's almost gone. But yeah, come on, people. Chat, chat, chat. I would love to hear more. This streaming thing is cool. I probably need to do this. Should I do this more? I probably should. It's the first time I've done like and I have not been as good at doing my YouTube videos. I probably need to focus on YouTube more. I like it a lot. There's just so many things to stay on top of. All right, people. Well, if we're good, are we good? I think we're good. Seems like people are enjoying. Got some hearts. That was cool. All right, people. I think I'm going to end my stream if nobody else has anything to say. So great to see people, hear from you, chat a little bit.